Thank you, Professor Harhalis, and thank you, Professor Tuduzes and Maria and the organizing committee for the opportunity to join you at this excellent symposium, all by digital. Um, just to say that congenital heart disease is a relatively new specialty over the past 50 years with tremendous progress. And catheter intervention for these patients, whether pediatric or adult, is part of day-to-day practice. It only started back in the 60s with balloon septostomy for patients with transposition, infants with transposition, and proceeded with valvular intervention with closure of PDA, and now extending into intracardiac defects, and I'll touch upon it, and also in dealing with stenosed vessels, coarctation, or with vessels that need occlusion. And it is good that you have us in the program because congenital heart disease is the most common infant defect. And Costas, your um, uh, father, always gets space for us because of the richness of the clinical material, the deserving patients, and the amazing hemodynamic conditions and changes that you see in this population. And you can see on this European Heart Journal slide from a review a few years ago that this is not pediatric disease any longer. There are more adults with congenital heart disease about, and some of them now approaching the end of the spectrum that Mark was discussing. This is the latest working group position paper regarding interventions, and that is a good review to visit as a summary of my talk, but also here to recent publication from our group reporting our experience over the past 15 years or so in heart, which is also worth attending to. We had the recent guidelines for adult congenital heart disease. We have moved from a reactive into a proactive approach. We're promoting for many patients a mixed model of care that they are part of a tertiary care facility like the one that you have at the Hippocratic Hospital for Athens and Greece. But with the exception of patients with a very extreme end of the spectrum, perhaps a combined healthcare model with the local providers is the best way forward. And I must say also that technology is part in the managing and also educating this relatively young patient population, and has come at the forefront in many ways during the pandemic. So cardiac catheterization diagnostic is limited today because we have so much in terms of non-invasive imaging and advances in it. So by and large, restricted for either patients who need to assess invasively hemodynamics, particularly primary vascular resistance, and or for patients who are referred for catheter intervention. And I'm grateful to Maria because she has kindly provided me with a large number of slides that you see here. You see here in this movie a patient who is undergoing balloon valvuloplasty for what seems like a native pulmonary valve, and that is a standard procedure, very effective. So I alluded to that the interventions that we started with was atrial septostomy for patients with transposition of great arteries who were diagnosed condition incompatible with life, so they would have an atrial septostomy as a prelude to eventually, at the time, the atrial switch procedure, master consenting procedure, closing holes or vessels, ASD, VSD, I'll come back to this, and PDA, opening vessels, balloon angioplasty, balloon valvuloplasty, stent implantation. And now what is routine, and in many ways, this all started from bone of fer, started from the right side. That was pulmonary valve implantation. Now more to the left side, and also TAV is a huge operation affecting a lot of patients of older age. One of the disadvantages for the infants is that the range of devices because of the somatic size, but that is not an issue for the adult patient. We can see here occluders. I'll come back to this, and we see also stents. So for some lesions, it's important to exclude that the patient has pulmonary vascular disease. Unlikely for the majority of patients, this is a very late complication for patients who have probably some genetic predisposition to it. For the vast majority of patients with atrial communications, specifically, pulmonary hypertension is not a concern. There are some patients who may have pulmonary vascular disease, and as you can see in this review from about 6 or 7 years ago in the European Heart Journal, there is an area borderline patients who still shunt left to right, mostly with atrial communications, some of them with ventricular communications, where the question about closing the defect needs thorough review. As you're familiar with, there are types of atrial septal defects, and the most common of them, secondary atrial septal defect that we see in the middle, is the one which is amenable to catheter intervention. And there are few and far between patients with secondary atrial septal defects today that end up having surgical closure. There are patients with primary atrial septal defect, ostium primum or partial atrioventricular septal defect, where the defect is part of an entity involving the atrioventricular junction, the left atrial valve, the conduction system, and clearly these patients are not suitable for percutaneous intervention. And there are patients with sinus venosus defects, high sinus venosus defects. Often, the majority of them have partial anomalous pulmonary venous drainage, and that is another area of advanced and exciting development between St. Thomas's, our partners, and ourselves. This is now patients who are considered for safe and effective percutaneous intervention by way of deploying a specially shaped and sized stent into the SVC to occlude the atrial septal defect, redirect the SVC flow, and also somehow the pulmonary venous drainage into the right atrium, thus avoiding open heart bypass surgery. In a nutshell, indication for ASD closure is a non-restrictive communication, not a PFO, and evidence of right heart dilatation. And one should do that at the time of diagnosis rather than waiting for overt symptoms to develop. And Maria has heard me before to say that atrial septal defects are not a right heart lesion, they are a left heart lesion, because the patients are subjected to systemic still through the defect from birth, compromising systemic flow. Once you close the defect, you restore systemic cardiac output, exercise capacity, well-being, and so on. Atrial septal defects are a right heart lesion if you sit on them. You have a patient with modest right heart dilatation who is not overtly symptomatic. You sit and wait the time-related complications, namely arrhythmias, right heart failure, and for a minority of patients, as I alluded to, pulmonary hypertension. So a proactive approach is what is the right thing to do, and what we do now for the adult patient with congenital heart disease. You can see some images again that Maria Dracopoulou kindly put together of a patient with secondary atrial septal defect with adequate rims. And you can see the range of devices available to us. Ambulature is one that is used extensively, safe and easy to deploy. You can see the advances on imaging that I referred to, where in a world of plenty, and that assists intervention that you can see here of percutaneous ASD closure under both transesophageal echocardiography and angiography. In the next slide, you can see the distal disc of the ambulatory device deployed, pulled back into the atrial septum defect in a good position, tested both ways for stability, and then released. 6 months after the intervention, there's normal endothelialization of the device. It can be difficult to visualize it directly. So it's a safe procedure, and it is quite a nature experiment, the dramatic change they introduced to this patient, that you can do this procedure not even under general anesthesia with intracardiac echo, and the dramatic implications that has by occluding the communication, improving left ventricular filling, and throwing a kind of a shout of additional blood into the systemic circulation. And indeed, because of this dramatic change for patients with atrial septal defect, as well for patients with coarctation who undergo cardiac catheter intervention, it is not uncommon to see a transient systemic hypertension, transient. The occasional patient, older patient with left ventricular diastolic dysfunction, and the challenge there to ensure that closing the defect would not lead to pulmonary edema. In reality, this is not something that you see in clinical practice. Test occlusion can tell you about it, and whether it's a dramatic rise in left atrial pressures, then you have to be cautious of proceeding with intervention or consider fenestrated closure. My slide is frozen for a moment. So moving from the atrial communications to ventricular communications, again, a range of types of VSD, the muscular, which is safe and suitable for percutaneous closure. The perimembranous VSDs, which are the most common, usually close to the aortic valve, which is a challenge, and that needs to be taken into account in specific anatomy. And the doubly committed subarterial VSDs, which are not suitable for catheter closure. We can see such a patient, the left top panel, you can see the VSD in close proximity to the aortic valve. I'm not sure whether you can see my arrow here. You can? You can. And then you can see tricuspid valve apposition. Thank you, Kostas. As you can see, tricuspid valve apposition around it, which leads to partial occlusion of this defect, and that's a common mechanism for it. What to remember, what is outlet for the left ventricle is inlet for the right ventricle. And you can see again here the area of communication. So this is potentially a patient who could benefit from percutaneous closure of the VSD. Just moving to the next slide. Again, if there is left heart dilatation, and make sure that there is no, the risk to interfere with the aortic valve is minimized. And contrary to atrial septal defects, for many of the patients with restricted VSDs that we are so contemplating closure here, many of them we do not, certainly do not consider them for bypass surgery, but if they're suitable for percutaneous closure, leading to offloading of the left atrium and the left ventricle, is certainly a good prognostic intervention to consider. You can see the muscular VSD devices. You can see that the shape is somewhat different from atrial septal defect, and that is to account for the risk of aortic damage. You can see a procedure here of VSD closure with a good result. PDA is, yes, a straightforward procedure can be approached either transversely or from the aorta retrogradely, and again exclude pulmonary hypertension. And usually they narrow down middle course of the duct and they're very amenable to catheter intervention. So indications for PDA closure, there are signs of left heart dilatation, left atrium is large, exclude pulmonary hypertension. Again, largely prognostic intervention. I have to say any volume overload of the heart of any etiology in the long term is not a good thing to have. Whether this is through shunts or through Gadsden valves. And in general, I don't know how much but we use chest x-rays a great deal. We're very keen to see patients having the smallest possible cardiothoracic ratio with chest x-ray, particularly if there's a target lesion. So there is such a patient with PDA underwent closure. The vessels. Coarctation, I think for the adult patient with coarctation, whether native or recoarctation, percutaneous intervention is a treatment of choice, and that's a major advance again because the traditional method of repairing coarctation was through left thoracotomy with long hospital stay, with a risk of paraplegia, with a lot of pain through the thoracotomy in the adult patient. And I think since the advent of balloon angioplasty and particularly primary standing for repair of coarctation, the results are excellent and the risk of the procedure in the right environment for the right patient minimal. So we'll see some examples of it. There is a patient who has quite a tight coarctation. You can see on the three-dimensional movie to the right a large subclavian artery with an extensive collateralization. And this patient has an excellent result following primary standing for it. You can see angiographic images of the same patient and a beautiful result from primary standing. There's another patient with extreme coarctation, almost interruption, and somehow retrogradely there is a way through. And again, you can see here the deployment of a wall cover stent, which leads to a good result and avoidance of a lateral. Keeping other vessels open. Distal pulmonary artery stenosis are common in patients, particularly with tetralogy, is part of this entity. I think what we're seeing here is a patient with tetralogy who probably had the left PT shunt, and that origin stenosis of the left pulmonary artery relates to this, and you can see a beautiful result following percutaneous stenting. Venous baffle obstructions, which are not uncommon in the setting of master procedure, that is atrial surgery. So the patients with atrial septostomy, a year or two later, they go back and they remove the atrial septum completely, creating a single atrium, and then they fashion a baffle to bring the SVC and IVC flow to the mitral valve, and what is left of the atrium allows for the communication of the pulmonary veins to the tricuspid valve. So in essence, creating a second fault in the circulation and making the pacing impede the patients with transposition. But imagine you got a 2-year-old infant and you make this, you fashion this baffle and you put it surgical, and then the patient grows the age of 10, 20, 40, and so on. So you can see why baffle obstruction is not uncommon. So catheter intervention with balloon and standing can be helpful. Many of these patients end up requiring pacing, thus maintaining patents of the baffle. Superior in particular is important. The Fontan operation, which is another radical step for patients with single ventricle physiology, that there's no ventricle to support the pulmonary circulation. A very radical concept of connecting either the right atrium or of latest the systemic veins directly to the lungs, provided that the pulmonary vascular resistance is low. And that very dramatic operation makes the patient's pain and he has a good result and longevity, all by Fontan patients, whether with the atriopulmonary Fontan that we can see here for patient of the great Magdiaco, who's still with us, and or the latest modification of the TCPC, total cable pulmonary connection, where these patients have a single ventricle and multiple with time complications that are reported. For these patients, for patients with moderate congenital heart disease, for all patients and for all of us, the best investment that one can make is to be slim and athletic. This is a new mantra. And we've all been through a difficult time with the pandemic, and we had to reflect what we wanted to do with our lives. I repeat myself, the best investment one can make for our patients and for ourselves is to be physically active, so exercise, and to pay attention to diet and optimal weight. Fontan obstructions are not uncommon. Again, there your catheter intervention has much to contribute. And then the valves, and this is Grunzig going back to the beginning of it all. And this is standard treatment now, both on the right and the left side. I think we're discussing the other end of the spectrum, and I'll be interested when I close my talk very soon to hear, as we are making these great waves with TAVI, where is the sort of younger aged population that we are considering for it. And we have some longer term follow-up data, but obviously these data pertain to an elderly population. We talked about the guidelines, we talked about complex congenital heart disease. You see here, this is Maria's beautiful slide, and she excludes patients with native diabetic valvular tract from consideration of pulmonary valve replacement, which is bread and butter now. If you look at adult congenital heart units, the most common, two most common interventions that we perform are ASD closure and pulmonary valve implantation, now percutaneously. And now, even for patients with a native diabetic valvular tract, the technology is there, and many of these patients are considered for percutaneous versus surgical intervention. Some of them require pre-standing before the valve deployment. This is the range of the valves available. And if we have the perfect prosthesis with good lifespan, maybe we should consider entering the prosthesis at the time of tetralogy repair, for example. But that is not the case. And of course, there's an issue of somatic growth.
Yeah.
I think I'm coming close to the end of my talk because I'd like us to have some discussion. I hope I'm not overrunning. We can see here the result of percutaneous pulmonary valve implantation in a patient who had pre-standing. And on the next slide, you can see the abolition of what was previously severe pulmonary agitation. So a safe procedure. The data that we have show excellent lifespan for about 15 years, similar to surgical pulmonary valve implantation. There are some concerns about valve infection in a minority of patients, and clearly valve-in-valve revisit of this is possible. So take this definitely into account in planning prognostic and timely intervention interventions for our patients. And again, the realization that congenital heart disease is a lifelong disease. And many of the patients continue to enjoy excellent quality of life, but that entails repeat procedures, many of them percutaneous. So again, Maria here highlights the issues and the proximity of the conduits to the coronary artery system that needs to be checked to make sure the procedure is safe. And some patients may require surgery because of that, but again, that is a minority. I think probably I should call it an end here. You can see more interventions. I could spend the next half an hour presenting interventions, but you got a flavor. And the flavor is that tremendous progress in catheter intervention, which is to the benefit of the patient. This is a tertiary multidisciplinary approach. We should never be deciding on what intervention is best for the patient in silo, but it has to be a discussion that involves the surgeons. Occasionally things don't go well, the surgeons are there to help us. And obviously you need to engage with the patients, but by and large, the patients, of course, they prefer a percutaneous intervention. It's an overnight stay, quicker recovery, and the multi benefit from it. Thank you very much for the opportunity, Kostas and Maria and Professor Hakalis.